Hi, my name is Jim Evans. I'm a professor of genetics and medicine at the University of North Carolina in Chapel Hill and the Lineberger Comprehensive Cancer Center. I'm also editor-in-chief of Genetics and Medicine, the journal of the American College of Medical Genetics. Breast cancer is indeed increasing in the younger population. That is primarily not due to genetics. It's primarily due to changes in our environment. Primarily, women are better nourished during their adolescent years. They end up beginning their period sooner. And the end result of increasing body weight as well as earlier onset of periods is that women are exposed to increasing levels of estrogen that they historically were not exposed to. What this has caused in many respects is a reduction in the age at which women get breast cancer. It's still a disease of the middle-aged and elderly woman primarily, but we're seeing more and more breast cancer in young women, for example, sometimes in the 30s and much more frequently now in the 40s. We're arguably entering a new era in medicine, and one that will be significantly informed by genomics and genetics and this burgeoning technology and understanding we have of the human genome. There'll be many advances that result from this increased understanding, including a better ability to tailor individual treatments to people, a better ability to, for example, select pharmaceuticals that will be more effective in one individual as opposed to another. One of the hopes of genetic medicine is that we will be better able to parse risk, that is, assign an individual to a high risk or a low risk type of category and therefore influence screening. And towards this hope, there has been a lot of activity and a lot of work that has identified now a number of genes which subtly affect breast cancer risk in the general population. And while these genes are extremely important, and this research is extremely important for better understanding breast cancer as a whole, it's not going to get us out of the screening and mammography conundrum anytime soon. And the reason for that is that the excess or reduced risk that these particular genes confer upon an individual are subtle. And we will not, for quite some time, I believe, have the power to really parse a population and allow, and say with any confidence to one group of women, you don't need mammograms starting at 40, and to another group of women that you do need mammograms starting at 40. So I don't think we're going to get out of our basic dilemma regarding mammography very soon. There is an important caveat to this, and that is a small number of women carry mutations in genes that confer a very large risk of breast cancer on them. And in those kinds of situations, knowing about those mutations can tell us a lot about what type of surveillance a woman should have. However, again, I would emphasize that those are rare situations, and the best and the most useful screening technique for finding those women, for picking them up in the population, is a very low-tech tool, and that's the family history. So I would encourage women and their medical providers to think about family history in decisions about screening. Because if a woman indeed has a significant breast cancer and ovarian cancer history in her family, then it may well be that targeted genetic testing could well inform their medical management. Again, I think genetics will not be any kind of easy or short-term answer to our conundrum with regard to screening. What we desperately need is clear. We need better screening modalities. And when I say better, I mean modalities that are more sensitive, more specific, and of course that are lower in cost. For now, we're kind of stuck with over-screening populations. And society as a whole will obviously need to come to conclusions, as will individuals in conversation with their practitioners, about the acceptable rates of false positives, false negatives, and cost, both in terms of morbidity as well as in terms of dollars.